I must admit, I woke up this morning thinking, I can't think of anything new to tell you guys that we probably haven't heard already, because what we recommend for treatment of malaria is the same as we recommended. I think the last time I was here was probably about 7 years ago. But there were some fortuitous events that came my way. The first is I got a WhatsApp from Gary Martins asking about my opinion on the role of PCR for malaria diagnosis. I thought, oh, that's an interesting question. And then I went to teach my fifth year medical students on substance abuse, not how to abuse substances, biology they are. And when I came back, I had an email from in my inbox, and I'm on a little group that is involved with updating malaria treatment guidelines. And this was the draft of updates for severe malaria treatment guidelines. So hot off the press, I decided, yes, thank heavens, I've got something new to tell you guys. So my slides are very rushed, still out of breath. You've got too many stairs, but I thought those would be quite useful things to focus on.
Yes, I noticed it's not that significant.
That's the arrow, double click. That should work now. Oh, great. So a little bit about the changing world in which we are working in malaria at the moment. And I know a lot of you are affected by similar things for other infectious diseases. The WHO guidelines I've mentioned. Also had two queries recently about people looking for MMed projects, master's projects, and they were thinking of doing a review of all the cases that have been admitted. And so I thought I'd tell you a little bit about the confidential inquiries we do, particularly into malaria mortality. But I think that how you look at those cases, how well people are being managed, might be of interest to some of you. And then because I spent all my time working on drug-resistant malaria, if you're not sick of me by then, I'll give you a little bit of an update there too. So there's just one changing climate slide, but I think we are reaching a time when malaria burden is going to get worse. And I reckon it's even going to be noticeable in Cape Town, not because we'll get malaria transmission here, but because of increased population mobility. We've got climate change, which doesn't always increase malaria, because we sometimes get drought, which decreases malaria. But overall, it seems to be increasing malaria. Population mobility is so great. I'm told that we need to be saving water, even though our dams are over 90% full, because the rate at which the population is growing in Cape Town, we're demanding more water. The health system itself is not as strong as it could be, and that has an impact. We will see more patients with more severe malaria because things are not happening in the way that they should. The wonderful era of global funding for malaria and infectious diseases and global health has been stagnating since 2015. And as you're all aware, it's gotten a lot worse lately, and I'm very grumpy with a certain person in the White House. We have a new vector, mosquito vector, that behaves really, really badly because it's an invasive vector species and it can thrive in an urban environment. So all of our systems that are beautifully set up for rural malaria, where you have a chief who makes sure the messages get out, and you can spray houses with DDT because they're structures that DDT adhere to. All of that's changed. But this new species, if we have port invasion of Staphylococcus, which we've seen at a number of ports, including Dar es Salaam, including in Eritrea, I think, is a real risk. We've got massive problems with insecticide resistance. South Africa's control program is almost entirely dependent on vector control that works. The effective insecticides that we need to be using now cost 3 or 4 times more than what we were previously using. As you know, our budget has gone down. So we're either going to be continuing to spray with something that doesn't work, or we're only going to spray a fraction of the houses that need to be sprayed. So that's going to be a big threat to our elimination plans. We've got diagnostic resistance in that you get deletions of the genes that make the antigen that our most widely used rapid tests use. And we've got drug resistance. So just when we thought we were there, we're going to eliminate malaria in my lifetime, it's not looking so good anymore. This I'm not going to spend a lot of time on, but it explains my grumpiness, or at least some of it. With the programs that worked in 27 African countries to avert 13 million malaria cases a year and over 100,000 deaths, have had their instant cut of their funding, and people have gone home. The records of the studies that they've done have disappeared, and you all know the story. And this is just the measure of the direct effects. All the indirect ways in which they strengthened the health system, provided the drugs, provided the rapid tests, weren't even included in these calculations. But I think what most of you spend your time managing is severe malaria. So this is where we're going with the neatly provided WHO guideline updates. And what you can see is that we were doing sort of okay towards our idea of reducing the number of malaria deaths. Then we had the stagnation of the funding. Then we had COVID. And imagine what's going to happen when we have Trump. It's just not going to look pretty. Sub-Saharan Africa is worst affected, 95% of deaths. 5 countries account for the majority of those deaths. Nigeria, DRC, Uganda, Ethiopia, a recent change there. We're actually doing quite well on malaria elimination. And then unrest and a few other changes, which go back up. And our neighbor Mozambique all carry the vast burden. So bringing it back down to a patient, this is a real patient. You can see the slides were made quickly because I deleted page 1 because I thought it took more time. This is a person. He's actually a very powerful person and public health. But a true story. When he was 60, he went on a public health consultancy to Nigeria, came back to South Africa, and serious workaholic, collapsed at work, and he was found to have malaria. See, as Nigeria has 27% of the world's malaria cases, it's a good thing to test for malaria if you collapse at work after visiting there. And so he was admitted to a private hospital at, I imagine, quite a high price. And he was treated with oral artemether for 3 days. He obviously wasn't being seen or paid much attention to, even though he's a very, 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 very important person, because he had increasing weakness, decreasing level of consciousness, and finally, maybe someone complained enough, he was put on IV quinine on day 4. So tens of thousands of rand, and he got probably one of the worst case managements I've seen of severe malaria. Someone collapses at work. That meets my definition, and therefore your definition, of course, of frustration, extreme weakness. So that's the kind of history that, even if there's no other feature of severe malaria, you would have diagnosed and treated him for severe malaria from the get-go. It took him months after discharge to be able to walk normally again. He said about 6 months before he felt himself. And so I think this is a good illustration of findings of suspicion. They got the diagnosis, but it didn't help him because they didn't get the treatment. And the risk benefit, if you're not sure how severe malaria is, I'm the person who gets malaria because I'm always jolly traveling, then please give me IV artesunate to start with, and then you can change to oral therapy, but don't err in the wrong direction.
So of interest, why did he get quinine and antimalarial?
Because he had a stupid doctor looking after him. So would have picked up from the diagnosis of uncomplicated malaria in the first place. So this was at a time when injectable artesunate was available in South Africa. It was still on Section 21, but I don't think that was an excuse. Third time lucky. Okay, I was going to ask you what you would have done differently, but I'm in a bit of a rush mode at the moment. So, when we do these confidential inquiries, this one we did ages ago, looking at malaria deaths in South Africa as a measure of how well the public health sector was working, we found that it took an average of 3 days for people to present. The WHO target, and for all of you who might get malaria on your travels, is under 24 hours, which is really difficult for something that has flu-like symptoms. You think it's COVID, you think it's flu, but no one seeks treatment at 24 hours, but that's what you should do. People think the condition is self-limiting. Quite often they think it's just a feature of their HIV or their diabetes or whatever else that's making them feel unwell. Sometimes they seek traditional remedies, sometimes it's socioeconomic constraints. And then even when they get to a health facility, almost 1 in 5 of them, and these was a confidential inquiry done in the malaria endemic provinces in South Africa, not Cape Town or Otago. They didn't suspect malaria in 18% of cases, and severe malaria was not referred for further management from the clinic in 14% of cases. So we were picking up hints that maybe all our training wasn't going so well. One of the things that really worries me is that lab results only came back within 8 hours in 43%, so less than half of patients. And in a lot of hospitals, people either don't use or they don't have rapid tests available in casualty. So the first time you get the malaria diagnosis comes when you get your lab result. So you think you've done your job because you've taken the blood, but actually you haven't got the diagnosis and you can get it in 15 minutes. So one of the things that we can do to enhance case management is to have rapid tests available at the point of care, rather than sitting in the laboratory and you get given the results with the result of your smear. Glucose assessment in people with decreased level of consciousness was done properly in 39%, smear requested in 46%, neurological assessment 58%. And so you can see that we are not, maybe they do more than they document, but you would think that in a severe malaria patient, it's notable whether someone has a normal level of consciousness or an abnormal level of consciousness. Either way, it's worth noting. And then the one that really made me even grumpier than I already am is that the worst time for anyone to get malaria, and the most common time for people to get malaria, is during Christmas and Easter holidays when there's much more crossing of the border. And that is a bad idea because clearly these people that are being paid to work on the Saturday and on the Sunday and at night are not doing so. And so 57% were seen at least once a day by a doctor. Initially, we expect you to see severe malaria patients at least twice a day because they change, they deteriorate. One complication disappears and another one arises. And even the nursing notes every 12 hours weren't always present. So that's something that I think you could include in your assessments. So this is the confidential inquiry form that we're currently working on for the Department of Health. And so you're looking for the things that would make people at higher risk. Were they pregnant? Was there a delayed presentation? Did they miss the diagnosis? What's the time that it takes from when you enter a hospital to when you get recognized as a malaria patient? It could be less than half an hour, but in most cases it's the next day. What complications are picked up? Is the right treatment given, or does this private hospital still give quinine out? Are the complications managed adequately, etc.? So these are all the things that we can think about in our own practice. Are we doing them right? Do we catch up? So going back to the question of malaria diagnosis, I recently have been in a rural part of Tanzania and I got sick. So being goody, I go off and I get a malaria test. I got blood taken, that's fine. I got a bill for almost 2,000 rand. Because they did a rapid test that was negative. They did a blood smear that was negative. And they did a PCR that was negative. And I was better in 2 days, so it was negative. But why do them all at the same time? Surely you do a rapid test. If it's positive, in 20 minutes you start treating the patient. If it's negative, okay, do a smear, repeat the test until you've got another diagnosis. You can start treatment if it's severe malaria. But it does not make sense to me that you should routinely do PCR. But PCR is useful because we do get false negative tests. I mentioned that the HRP2 deletions mean that the rapid tests don't work everywhere. South Africa, we have done so much genotyping and we don't have any HRP2 deletions yet. So I think we're fine. Sometimes people read the rapid tests quickly because they're running late like me, and then you miss a diagnosis. Smears or rapid tests, when they're badly done, you can miss the diagnosis. Smears can be negative if someone's taken malaria treatment. And obviously in endemic areas, there's a lot of self-prescription of antimalarials. So the guidance is that until you have a diagnosis for your severely ill patient, whether it's confirming malaria or you find something else, you can repeat the malaria smear every 12 hours. And you get a lot of fluctuation of parasitemia. And some people get a fright is that you start treatment and the parasite density climbs. So my take-home message is save your nerves, save money. Do not repeat the malaria smear 6 hours after it was positive. It will still be positive and it won't help you at all. You can repeat it on day 2 or 3, by which stage our test unit, if it's working, should have the majority of parasites working. We're going to talk a little bit about concomitant infections. So blood cultures are often useful. Knowing someone's HIV status doesn't change your management, but there is a higher risk of some complications being more prevalent and mortality rates can be higher. It's very controversial about lumbar punctures. And the lumbar puncture debate comes in 2 camps. These are usually people who work in endemic settings where most people running around attending school are malaria positive. So you have a child with a decreased level of consciousness and a positive rapid test, but that doesn't mean that treating the malaria alone is going to be the solution for that child. And if there are features that are suggestive of a meningitis or encephalitis, then of course people want to do lumbar punctures. They're nervous if there's any risk of coning. You obviously are not going to do it if you've got papilledema. And most people, I think on the conservative side, but rational side, will treat as if it's malaria as the only problem. And you have a very, very low threshold for adding an antibiotic so that you would be covering for a meningitis without putting the child through the risk of doing a lumbar puncture. In places like South Africa, the chances of someone having an incidental positive malaria test that's not the cause of their illness is obviously a lot lower. So our life is simpler, much easier. Why are smears useful? So we have the most wonderful resource for these severe malaria guideline update for the WHO. In that people like yourselves who've done studies on severe malaria patients have donated, they shared their data with the Worldwide Antimalarial Resistance Network, and we now have about 40,000 individual patient data on people with severe malaria. And then we can start using that data to inform guidelines rather than some old wise man who's balding deciding that this is the way to do things. And so what we found, I didn't say that out loud, right? So what we found is that microscopy is very useful. You can have, in fact, I've seen patients who have no clinical features of severe malaria, but you do a smear and more than 5% of their red blood cells are infected with malaria. And that alone is enough to double your chances of dying, which for me means it's nice to call that person severe malaria and give them artesunate, because then you reduce their chances of dying. So that's the interesting part here, is looking at the parasite density and what impact it has on mortality. But it's a bit confusing in that it's not linear in the initial parts of the graph. So the reason why I'm showing you that complicated picture is that if your parasite density is not above 5%, that is not reassuring. That does not mean this patient hasn't got serious severe malaria. It probably just means that the red blood cells are all busy sticking to each other until the end of the ileal lining, so you're not seeing them. But if it is high and it's above that 5%, then you know you've got a high mortality and you need to manage that patient for severe malaria. So don't be falsely reassured in this phase. If any of you work in the lab, you are better at explaining the next graphs. But one of the most useful indicators of severe malaria, aside from the parasite density from smear, is looking for pigment in your neutrophils and in your monocytes. And if you have an increase in pigment, you have an increased risk of severe malaria. So don't think that someone's just doing an academic exercise when they tell you about the presence of pigment in the cell. That's worth taking seriously as an indication of severe malaria. Severe malaria is mean, and what often happens is you don't have one complication. You only need one complication to have severe malaria, but unfortunately, children and adults have a constellation. So here you can see the overlap of children that have cerebral malaria and renal impairment and acidosis. Big triad. And with each complication, your chances of survival goes down. In adults, it's cerebral malaria, acidosis, anemia, which we'll discuss later, and some uremia. And you can see that overlap happens. And it changes over time. So often I've admitted someone to hospital with normal renal function, and just when I think we're winning, they're waking up, level of consciousness is great, then you see the renal impairment start. And so you have to monitor those changes over time so you can manage them. This is the new improved, hot off the press from this morning, classification of strict definition. This is like for research to make studies comparable, definitions of severe malaria. And how we've done that is on that massive database, if any feature is associated with over a 5% chance of mortality, then it goes on the list. If it is not associated with over 5% mortality, we kick it off the list. And we can choose the thresholds by looking among people, for instance, that have hypoglycemia. At what threshold does your mortality climb up to above 5%? And what we saw is we used to call hypoglycemia below 2.2 as the threshold. We now know if it's below 3, you're still in trouble. You have over 5% mortality. So that's going to change. Similarly, in children, the previous definitions of severe malaria were underestimating the mortality risk. And now any urea above 10 is enough to know we need to worry. Luckily for you and me, the rest have stayed pretty much the same, with one exception that I will come to. The other thing that's quite nice is one gives you a prognostic value, and you get to understand what the harm is of having pulmonary edema. And the other will be the things that you expect to see frequently, which is good for a health system and being able to manage what needs to be available at what level. At a clinical level, that's too complicated and it's just for researchers. So they've created high risk, moderate risk, and low risk severe malaria people that will be treated with injectable artesunate. So if you prostrate, please tell the doctor that looked after the patient we presented. Respiratory distress, shock in children, those are your most serious children. You need to manage with all your attention. In adults, the same 3, with the addition of anuria and GIT hemorrhage, which is a new addition to the list. There's a debate about anemia, which I'll discuss. Repeated convulsions in children, just repeated because they have febrile seizures, which might not be a feature of cerebral malaria. Hemoglobinuria and jaundice is quite uncommon in children, but it's still a severe feature. In these situations, if you are in a place where you can't give injectable treatment, you can't get a dripper, you can start with oral treatment, and as soon as you're able to, you can move to injectable treatment. But I think in your settings, you'll be able to give IM if you're not able to give IV.
Karen, on the previous slide,
Yes.
in the table, the prostration was only a prognostic value of 1+ compared to others, yet is the group the most significant in your next slide. So how does that vary up?
Good question. I think that the criteria that cause us the most grief are the ones that are common and multi-causal. So you're feeling sick because you have flu, you might be staying in bed, and so it's not an easy marker. So because it can be a marker of cerebral malaria, we take it seriously. But if it's someone lazy like me, then you might, so it's too, I think it's too non-specific to be a good prognostic marker.
Okay, so it's the issue of whether it's your prognostic marker rather than
Exactly.
correlating it with
health.
Okay.
But I think what we also want is all of these decisions are in the grey zone, but they're the risk-benefit assessment. So if someone is too weak, it comes into a private practitioner just leaning on their daughter's arm or something. Those I take very seriously because they might be a sign of significant weakness. But it is a vague symptom. And we haven't got a magical medical test to quantify it. Okay. The other one that has the same problem is anemia. So in the current guidelines, we say if an adult has a hemoglobin below 7 and a child below 5, that's severe malaria, just based on it, even if you've got no other feature of severe malaria. And yet, when they looked at that massive database, there's actually no correlation. Lots of people have hemoglobin below 7 and a low risk of dying. And so, from the database alone, they only started seeing an association with mortality below 4 grams per deciliter. I'm not sure that we are going to change the guidelines to that extreme. Or we're just going to move adults down to 5, or we're going to give a big blurb about how common chronic anemia is, the areas where you get malaria, you get anemia from a zillion other things. So that's a very debatable area. But if you take the 5% mortality threshold, the current definition would be kicked out. The other thing that's really important to consider is acidosis. And they've drawn this very nice curve showing your chances of dying. If you are very acidotic and you are comatose, your mortality goes above 60%. If you are not acidotic but comatose, your mortality goes down to, I don't know what that is, about 10%. So a massive difference because of the acidosis. And you can look at it, that's where they got the threshold of 15 from, which has previously been defined. Clinically, deep breathing without any abnormalities on auscultation might be all you have. And we want those clinical indications because you want to make that decision before you get your lab results back, or when you're doing community service in places where you don't get lab results as easy as we do. The other thing where you can get lots and lots of brownie points if you get a severe malaria patient in the clinical exam is looking for retinal abnormalities. And about 20% of patients with severe malaria will have a retinal abnormality, 40% with cerebral malaria, 80% of fatal cases. So it's well worth spending some time to look up some of these things to understand what you're looking for. So you get this patient over here has got a massive hemorrhage, the big brown patch. It's one of your toys of the winter. Okay, so here's your retinal hemorrhage, and you can see it's got these whitening patches that are that's like a typical severe malaria picture. You get the whitening patches also where the white arrows are, and you've got smaller hemorrhages where the black arrows are. So you can see these are the changes that we get. And then when you've got intracranial pressure that rises, you have hypoledemia. So those are the 4 things you would be looking for in severe malaria. Treating malaria. This was the bit I was worried about because I thought it's boring, you know it all. Please give artesunate, not quinine. It has numerous advantages, particularly that you're less likely to die and that it has more rapid parasite care. It's much easier to give a simple dose regimen, better safety profile, including in pregnant women. One of the places where persistent use of quinine is given is when people are scared to use a new drug. It was reported in 380 AD in the Chinese Handbook of Emergency Meds. This is the new drug that they're scared to use in pregnant women. But your mortality in pregnant women is much higher than in non-pregnant people. They did a case series of hospital admissions to Baragwanath ICU for severe malaria. They did not have a single pregnant woman admitted to ICU that was discharged alive. So that was, for me, when I realized how difficult it is to manage, especially the fluid balance in pregnant women with severe malaria, that please give them the most effective treatment in all trimesters. And we don't need dose adjustment, and it's the drug you should be using. Forest clocks on a Friday afternoon are not ideal, but I find this one quite interesting. If we look at all of the studies done in Asia, where the majority of patients, like in Cape Town, are adult patients, 80% of malaria cases in South Africa are adults, then you get a 42% reduction in your in-hospital mortality rate if you get given artesunate over quinine, which is very persuasive for me. If you look at the studies in African children, then you see a 25% reduction in mortality. So there was lots of head scratching, thinking, well, what is it that makes artesunate have less of an impact in children than adults? And all of the research since then has concluded that it's because we're not good at telling the difference between incidental malaria on another condition that then doesn't get treated adequately or doesn't get treated initially. And so that's probably the main reason why we find a difference. We haven't found any other explanation yet. You all know about the use of artesunate. The take-home message is that if you decide it's severe malaria or could be severe malaria, you start artesunate and you give at least 3 doses at 0, 12, and 24 hours. The milligram per kilogram dose needs to be higher in children because they metabolize the artesunate faster, and we don't need to dose adjust for the renal impairment that's very common in severe malaria. Luckily, we don't have to do this because we have lovely nurses that manage, but it's a very unstable compound, so you have to mix the powder with bicarbonate just before you give the dose. And because it's unstable, you can't then keep what you mixed for later use. And the main message is people with severe malaria have the highest parasite densities, the biggest risk. You cannot just give the artesunate and then send them home. Even though their smear is going to be negative, we can have 100 million parasites in our body, and our malaria smear would still be negative. So we're not very sensitive about this thing. So we've suppressed the parasitemia, but they need to finish a full course of artemethyl lumefantrine after discharge. I'm particularly passionate about this because they think that the use of injectable or rectal artesunate without completing the treatment, sometimes in uncomplicated malaria, sometimes in no malaria at all, is one of the big drives for why we've got artemisinin resistance concentrated in particular countries in East Africa, like Uganda, where that's quite common practice. The safety is very reassuring. A lot of symptoms overlap with malaria symptoms. The things worth knowing about are delayed hemolysis, particularly in people like you and me who are non-immune, and particularly people with high parasite densities. It's worth getting them back after 2 or 3 weeks, checking their hemoglobin. We had a 11-month-old infant in Bloemfontein, of all places, with malaria, and their hemoglobin dropped to 4, 3 weeks after being treated for high parasite severe malaria.
We just had one admitted now.
Okay.
There was 31% parasitemia. And God articulate his hemoglobin dropped to 4 out of 4.
Yeah.
I was just trying to work out what it was when you went home, but it couldn't that same way.
It's 8.
Now it's 4. It came in and a seizure 1 week later.
Yeah. Nice case for my collection.
Yeah.
I mean, get notes from you. Okay, so I didn't need to tell you that because you've now all got it in your memories. The concomitant sepsis story I've indicated. So what we do is different for children and adults. And I know you mostly treat adults. It's not so common. But if you have an adult with a clinical syndrome where you expect a bacterial sepsis or bacterial infection is likely, whether it's meningitis, they're malnourished, immunocompromised, severe pneumonia, could be, or, and this is new, wasn't in the previous guidelines, if you have a high parasite density, your chances of dying are on that climbing part of the curve. And so the risk of missing a bacterial infection because you're focusing on malaria treatment is too high. So that's when we recommend giving concomitant antimalarial. We're not trying to drive up antibiotic resistance. We're not trying to overuse antibiotics, but it's the risk benefit in terms of deaths. For children, they say about 6% will have sepsis. And it's really, really hard. There is no magic clinical test that will differentiate primary sepsis with incidental malaria or severe malaria being the cause of illness. And so that's why we have a much lower threshold in children for treating with antibiotics initially, empirically, and then once we have results, being able to narrow it down to what is recommended. So they say all children with severe malaria, it used to be children under 5 or children under 2, with intermediate or high malaria transmission, which is basically what proportion of the healthy population is going to be parasitemic anyway, should get broad spectrum antibiotics with their treatment. I think that's going to cause quite a lot of debate. I'm not sure how it will come out in the guidelines, but that's their risk-benefit assessment.
So the other marker I've always used is for high white count, but it's not on there. So what do you think?
I think that would be a good indicator to consider because quite a few of the cases I've been looking at recently in this mortality series, they all had low white cell counts, but I think with high white cell counts, it would be a good reason to give it. So I think we are probably going to have to find a way to get that balance better. That's a good suggestion. I will add it to my recommendations. Pretend I'm clever.
I'm sure what you told me is
there's nothing new I can tell you about dialysis or renal replacement therapy. The indications we use are exactly the same as you would use generally, regardless of being malaria or something else. But we were able to show a difference in mortality if the dialysis was started in less than 2 hours or after 2 hours. So that's something that is going to be a real challenge for us to pick up and respond to early. So we have to up our game there a bit.
Sorry, just on that one, because
this is a big one.
Yeah, so your bills are going to go up. Yeah,
it's a big one because, I mean, as you indicated in the other slide, the risk of 5% mortality. So a creatinine of just, I think, 65
yeah.
is that. And I think you're highlighting that invariably these patients are deceptive. And we have this engagement with our renal colleagues about early dialysis rather than later. So it would be interesting how it features in your new guidelines as how that debates, in terms of how strongly you indicate dialysis earlier rather than later for other indications. Because once they've got volume issues, you almost lost the plot, or the acidosis is uncontrollable. Yeah.
I mean, we have different problems. I've generally found that because malaria is not that common And because it is a treatable infection, it's actually easier for a renal unit than chronic dialysis. So at least they're not buying into lifelong dialysis. Our big problem is mostly that malaria is diagnosed in areas where you don't have access to dialysis. And I remember a debate about, do we do peritoneal dialysis up on the Mozambique border, or do we transfer this patient to Durban or Richards Bay? And it takes so long to get there, they deteriorate, and the risk benefit is really difficult. So I think it would be interesting to look at those data and see how well they've adjusted for covariance, because you can imagine that by the time the patient is that acidotic, it might not be the renal impairment per se that's the big challenge, or their fluid balance is a problem. So I think that that's something that will change. And actually your comments will help us know which points to push back on and debate and get more evidence on. So please all comment. Then my last reminder, and this is really just going to be brief, is that it's a wonderful opportunity to educate patients to not get malaria again. Most places where we work, you have the same people coming back with malaria, not because it's a treatment failure, just because they travel to and from areas. And so what we need to do is remind them about avoiding mozzie bites. And the big news is that we finally got doxycycline on the essential medicines list for malaria prophylaxis. And even though people think of malaria as pregnant women and young children, in South Africa, only 1% of malaria patients are pregnant women and under 10% are young children. So we can use doxycycline and it is available. And what's causing, you have pharmacists in your causing a lot of grief for pharmacists is that doxycycline is available over the counter for malaria prophylaxis, but not for all its other indications. And apparently that makes life very difficult. But we're delighted that it's available over the counter and people can get protected from getting malaria before they travel. You know about people like me needing lots of sunblock and needing to take their doxycycline standing up, full glass of water, all the nags, not in children and pregnant women. Watch out for drug interactions. You can take it for up to 2 years. Drug interactions. A lot of people ask me about alcohol. I don't know what they do on their holiday that they want to interaction with us society. But generally, if you're a chronic alcoholic, then your liver is going to be gobbling up your doxycycline. You might need a higher dose, but you might not tolerate it. Acute binge drinkers, none of you, but that doesn't really cause doxycycline that you're taking every day. Antacids reduce absorption, so you want to separate the timing. Iron, same story. Some of the anti-epileptics can gobble up the doxycycline, so we generally double the dose. Instead of 100 milligrams a day, we get 200, but your stomach does not tolerate 200 milligrams of doxycycline, so we split the dose morning and evening. It's fine. Increased risk of pseudotumor therapy. I've never ever seen a case with doxycycline, but it happens. Reduced efficacy with rifampicin, same with anti-epileptics. And with warfarin, no surprise, 1 to INR, there may be an interaction. All the emphasis on compliance, the challenge is that people don't take prophylaxis for weeks after they return. But for the rest, actually, before topical was available, it was my go-to malaria prophylaxis. And it's a very good way of losing weight because you have this sort of chronic nausea. Okay. Last one, drug-resistant malaria. I have to mention because, of course, it's so important. You know that artemisinin resistance is now in Africa, and that artemisinins are the backbone of our current malaria treatments. So we're not happy about the fact that in the Horn of Africa, Uganda, Rwanda, Tanzania all have confirmed artemisinin resistance. But confirmed doesn't mean very much. It just means WHO has finally got around to agreeing that this is confirmed malaria resistance. But we have the same mutations with the same problems. right on our border in Namibia. I did a case management session with the Western Cape government. They told me the majority of malaria patients in Cape Town got the malaria in Namibia. I would never have guessed. And we also have artemisinin resistance in Zambia. Zambia, it's over 30%. In Namibia, it's over 40% of parasites tested. So this is not a distant future problem. This is almost upon us problem. What's very worrying is that the artemisinin resistance in Africa has actually spread and increased in prevalence at the same rate that it did in Southeast Asia. We hoped that in areas of intense transmission intensity, you would have some of the partial immunity suppressing the spread of resistance. You would have multiplicity of infections breeding out resistance. No such luck. It's not just that we have mutations, which are very hard to make policymakers excited by, surprisingly, but we have first-line artemether-lumefantrine treatment failure confirmed in Uganda, in Kenya, in DRC, and in Tanzania. And so a lot of the other places where we have those resistance mutations, like Namibia, they've never done an efficacy study. But the last malaria season, they had a huge surge in malaria cases. And it might be that the resistance is what has increased the malaria cases. So you have a delayed response to treatment, you have recrudescent infections, they have more gametocytes. Gametocytes are the baddies that take the malaria infection into the mosquito and the next person. And so you're going to end up with more transmission, more drug pressure, more resistance. So it's a catch-22 situation that never gets less as far as we can see. So what do we do? So artemether-lumefantrine and ACTs remain our first-line treatment, and they remain effective, if you're lucky. But sometimes you need to supplement it. And in South Africa, we're in a difficult position because we only have one artemisinin combination available, because our market is so small, no one is interested in dealing with SAPRA for 2 or 3 years to try and get another drug on the market. But what can we do? So the immediate thing we can do, and what we currently recommending, is that instead of giving a 3-day course, you can double the number of boxes that you give, and you give 6 days of treatment. So you can't double the dose because you can't absorb more than 4 tablets of artemether-lumefantrine in a go. But you can keep giving it for longer. And so for a while now, we've been recommending if someone is on, say, rifampicin, they are at a high risk of treatment failure. We can't do anything because we've only got one drug. And so that's when we've recommended a longer course. But if we get to the point where artemether-lumefantrine is starting to fail in South Africa, we have no other treatment. That's our one option. The other option that we've already started to implement is in endemic areas, not Cape Town, but especially the northern areas of Limpopo, eastern Mpumalanga, a little bit in KZN. We give single low-dose primaquine, which kills those gametocytes, which stops the transmission of malaria. And we're hoping to do a large-scale study to see if that can reduce the transmission of resistant malaria. So if any of you go and work in endemic areas, the other thing you can do for every patient you treat, give a single low dose of primaquine, unless they're pregnant, and please don't give it. You can postpone until after they're pregnant. Other options in normal countries where they've got lots of ACTs is they can switch ACTs, they can have multiple first-line treatments. You can combine artemether-lumefantrine with artesunate amidiaquine, which they're busy studying now as a fixed-dose combination. And the newest kid on the block is something called ganaplacide-lumefantrine. Ganaplacide is going to replace the artemisinins. Here's parasites amazingly even more rapidly than artemisinins do. They will finish the clinical trials for registration by the end of this year. They hope to submit the dossier next year and get licensing, WHO pre-qualification, etc., by early 2027. So if we can keep our current drugs effective until then we've got an easy solution. But if we mess it up and we lose lumefantrine, we lose ganaplacide lumefantrine, and we might also lose the ganaplacide because there's too much pressure on it. And what you can't see down here is that you can't combine artesunate amidiaquine with lumefantrine in this triple combination they've spent 5 years developing if lumefantrine isn't working anymore. So we have really good reason to try and hold on to the drugs that work. This picture reminds me that